So hi everyone, thank you for attending the presentation today. My name is Rebecca and I'll be presenting on behalf of my colleagues, Lawrence Gerson, Janelle Panday, Henry Sue, Allison Baker, Elena Alice, and Meredith Vanstone. Today I'll be speaking about our project, The Impact of Care of the Elderly Certificates of Added Competence on Family Physician Practice. And these are the results from a pan-Canadian multiple case study. And this work was completed as part of my HRM PhD independent study project. So just in terms of a disclaimer, this work was supported by the College of Family Physicians of Canada, and the authors do not have any conflicts to declare.
Sorry to stop you, Rebecca. I can't see anything on your screen. I'm just seeing a black screen. I don't know if that's just me.
Oh, really?
I'm just seeing black.
Oh,
Okay.
I could see your screen though.
Okay.
Is that better?
I still see it before as well.
Okay, for some reason I'm only seeing black. Okay, if everyone else can see it, that's great. Keep going, and it's okay. I can see it now. All right, sorry about that. Please continue.
Okay, perfect. No problem. All right, so to start off with some background, older adults who seek primary care services often have greater medical care needs due to frailty, multimorbidity, functional decline, polypharmacy, and transitioning across different healthcare settings. So family physicians actually provide the highest volume of medical services to older patients compared to all other specialty groups, but they often report different degrees of preparedness and interest in caring for this patient population. So the difficulty to care for older adults might reflect variable medical training and experience working with them. So recognizing this gap in medical education, the Professional Association and Certifying Body of Family Physicians, which is known as the CFPC, established the Care of the Elderly Certificate Program. Since it began, over 414 family physicians in Canada have earned the COE designation through residency training or practice experience and professional development. However, the impacts of the COE program on primary care delivery and group practice is largely unknown. So this study is aiming to examine the impacts of the COE program on how groups of family physicians provide care to older patients through an analysis of multiple cases across Canada. And so this investigation was organized around the research question: how does COE training and certification impact the way primary care is delivered to older patients? By examining the roles of family physicians in caring for older patients, including those with and without the COE designation, this study will provide some insights for continued investments into geriatric-focused medical education, as well as primary care organization. So this study used a multiple case study design, and it was actually a secondary analysis based on an original CFPC study, which obtained data about a variety of certificate programs offered by the college. And so I conducted a secondary analysis of 6 instrumental cases from that original study, really focusing on that COE program in particular and primary care delivery to older patients. A multiple case study design allowed for an in-depth exploration of variation and diversity within and across different cases in Canada, and it also allowed for us to consider the broader organizational context in which primary care is delivered. So we defined cases as a practice or a collective of family physicians who worked within a defined group of patients in an interconnected community. And we also applied an embedded nature to our study design, which allowed for physicians to be positioned within the case and also the broader context to examine potentially contrasting aspects in how they cared for older patients. And so this figure provides a nice illustration of the design of our study and also the analytic approach that was taken. So you can see here the 6 instrumental cases and how they were sampled and set up. You can see that older adults were part of the patient population in all of the cases. Some of them included those with the COE designation and other types of credentials as well among the family physicians. And so that primary data source that we analyzed as part of this study were key informant interviews within each case. And so the interview guides were organized around the theoretical propositions of the original multiple case study. But we did ensure that there was congruence between the objectives of this secondary analysis. And so essentially, we performed a descriptive content analysis using a staged coding process. So the first step was really about immersion, condensation, and summarization, which allowed for subsequent iterations of our analysis to develop categories and subcategories within the data. We also conducted a thematic cross-case analysis to look for themes and explore similarities and points of distinction across the 6 cases. The analysis began with an unconstrained inductive fashion, meaning that we didn't have a plausible existing theory that we were applying. And so the findings from each case informed our approach to coding subsequent cases. So while coding, we documented analytic memos to capture potential avenues for analysis and different patterns. We engaged a second coder to apply the code book from a different perspective. And we discussed themes and patterns among the full research team, which included a mix of clinicians and health systems researchers. We also maximized 4 aspects of methodological quality and rigor, which are essential to case study, listed on this slide here, using a variety of strategies. And the original multiple case study was reviewed and approved by the Hamilton Integrated Research Ethics Board, and participants provided their verbal and written consent before interviews. So this slide provides an overview of the participants in the case study. So we had 48 participants in total, which included physicians, resident trainees, and administrators across a variety of regions and training sites in Canada. And all groups of family physicians cared for older patients, which really affirmed the relevance of the cases. You can see here that there were specifically 39 family physicians, 6 resident trainees, 2 administrative staff members, and there was 1 geriatrician. There were 20 family physicians who held one of the college's certificates, 6 of whom held the care of the elderly, or that COE designation of interest. And except for those in case 2, each case did have at least 1 COE holder. So now I'm going to get into our findings. So essentially, we observed substantial differences in how individual COE family physicians function and deliver medical care collaboratively across different settings, contexts, and regions in Canada. And so we used the summary figure on this slide to show the interconnected ways that COE training and certification influences the care of older persons. And we organized these impacts across the patient, the healthcare provider, and the practice levels. And so using the metaphor of frying an egg, which you can see on this slide, it really demonstrates that interconnected nature of each level in the successful care of providing care to older patients. So I'm going to start off by talking about some of these impacts on the patient level. So these include greater access to geriatric care, care continuity, comprehensiveness, and community adaptive care. So having greater access to the COE family physicians was thought to reduce wait times for older patients and to streamline referrals when seeking specialist care. So this lessened the burden for patients having to travel and seek specialist care elsewhere, especially if they were located in more remote areas. The program also enabled some family physicians to deliver specialized geriatric services like memory care consultations within their primary care setting. In terms of continuity, the COE programs facilitated this by enabling providers to support patients as they aged. However, some regarded this in a negative way, in the sense that when specialists are kind of coming in and out in that care of older patients, this is a little bit advantageous to preserve that patient and family doctor relationship, such as when diagnosing stigmatized conditions like dementia or when discussing lifestyle changes like driving. In terms of comprehensiveness, the program allowed for some physicians to maintain a generalist practice others, and for some others, they might have focused a little bit more on providing comprehensive care to a specific group of older patients. In areas that did have fewer specialist resources, in general, again, they might have been in more of a remote area, the COE docs really seemed to transition away from maintaining the generalist practice to focus on older patients more intensively. And then lastly, across cases, we saw that the COE credentials enabled providers to practice in a variety of different healthcare settings. So there were conversations about practicing out of outpatient clinics, inpatient units, memory clinics, home care settings, and nursing homes, in addition to their more traditional roles in a primary care practice. And then we identified a variety of impacts on the provider level. So after earning the designation, many COE family physicians talked about having greater confidence to care for their older patients, and they felt less like an imposter, such as when talking with different specialists. So this designation, or this formal title, really empowered them to conduct some of those complex assessments or pursuing research and things associated with geriatric medicine. Some COE docs believe that their designation was recognized by colleagues, whereas others felt that it didn't actually impact their professional roles or opportunities. So some colleagues who worked alongside COE family physicians who were interviewed here revealed that they didn't actually understand or appreciate the designation when in practice. There were a lot of discussions about the multidisciplinary nature of geriatric care and how the COE designation really enabled conversations in under-resourced areas, such as those lacking access to geriatric specialists or geriatric psychiatrists, for example, and allowing for more collaborations when it comes to things like behavioral issues or providing dementia care. Some family physicians also talked about how the COE designation enabled them to conduct some quality improvement or research activities that they might not have pursued otherwise. In terms of hiring choices, some reflected on that certification providing some job security, but there were mixed opinions about whether it was advantageous or not to have the certificate. But for those who completed medical training outside of Canada, the COE program did provide an opportunity to recognize intensive training in geriatrics, so they might have obtained elsewhere. And then lastly, just in terms of work-life balance, the COE designation seemed to impact the boundaries between personal and professional lives, but to no greater degree than maintaining a general family medicine practice. And then lastly, I'll just speak to that practice level. So in terms of human health resources planning, some family physicians felt motivated to pursue the designation so that they could adequately care for their aging patients within their group practice. In regions where healthcare services were under-resourced, the need for generalists was actually paramount to the needs of that particular group of older adults. So that was kind of favored rather than maintaining a little bit more of that specialist practice to meet the diverse needs of the community. Some family physicians perceived that their role of acting like an expert resource after obtaining the designation was worthwhile, but others, family physicians, were hesitant to pursue the COE training because they didn't want to function like a specialist. That's why they went into that's why they went into family medicine, to kind of have that comprehensive scope in providing care to patients. And then lastly, for remuneration, many COE holders talked about the costly process to step away from their practice to pursue the training elsewhere without any financial incentives. But a lot of physicians reflected on the fact that after earning the designation, they were able to pursue salaried funding models, which allowed for more extensive care for their older patients beyond that traditional 15-minute appointment. So just to conclude here, our analysis of COE training and certification is one of the first efforts to explore the impacts of this program, and the multiple case study design allowed for us to identify and explore differences in the practice of these physicians, as well as to consider the perceptions and attitudes using a qualitative methodology. The impacts of COE training and certification that we identified aligned with some of the original objectives of the credentialing program from the CFPC. So overall, these certificate programs really seem to be responsive in addressing the needs within the community and maintaining care continuity between primary and tertiary care services. And so this secondary analysis was limited by the original research questions, objectives, and scope within that original study. Again, this was a secondary analysis. So we were kind of removed from things like participant recruitment or constructing the interview guide. So the breadth and the degree of detail from the original transcripts was a little bit limiting, I guess, in terms of reaching our research objectives. And so just to finish things off here, so given the widely recognized need for more geriatrics focused providers in Canada, it's important to understand the ways in which family physicians with specialized credentials and formal geriatrics training can care for older patients. So as this number of older adults continues to grow, COE family physicians are in a unique position to fill knowledge and practice gaps. There's a few references on this slide. Some are methodological and some are topic references. Yeah, I think that's everything for me.